As we let people come into the webinar today, I wanted just to say welcome. This is the Carers Knowledge Exchange Webinar 7, Carer Engagement in Healthcare Settings. My name is Hugh Bainbridge, and I'm an Associate Professor in the School of Management and Governance at the University of New South Wales, and also representative of the Research Advisory Group for the Carers Knowledge Exchange. Today's session will be recorded and shared for on-demand viewing. The session will be available through the Carers Knowledge Exchange digital platform if you want to catch up on that discussion, and the link will be shared in the chat for today. So I just want to start by acknowledging the traditional custodians of the land that our panelists and attendees are joining from today. And for me, that's the land of the Bedegal people. I also wish to pay my respects to elders past and present, and to all First Nation carers and communities. As I noted, today's interactive webinar, Carer Engagement in Healthcare Settings, will focus on what the evidence says about good practice for engaging with carers in healthcare settings, and opportunities to inform concrete policy and practice solutions. At our last interactive webinar in August, Rethinking Care Empowerment and Resilience, we focused on how carers perceive the ideas of empowerment and resilience, and including what those concepts mean in the context of healthcare systems. And carers at that point stated real empowerment involves everyday challenges they experience being both acknowledged and properly addressed. And they also shared that the service systems should do what they can to improve navigation, rather than putting the onus back on carers and adding to their already heavy load. We also heard that healthcare professionals often want to better engage with carers, but they don't know how to sometimes. And the research evidence can provide us with some useful tools and insights to help us to address that gap. So the insights that I drew upon before, today's webinar builds upon those to explore what the evidence base can offer, asking the carers, researchers, and policy makers and practitioners present today to help us to apply those insights to real-world healthcare initiatives. The webinar will last for 2 hours, including a short break halfway through. We'll start with a panel discussion featuring some research and lived experience perspectives, followed by workshop-style conversations in 3 concurrent rooms, breakout rooms, that you will have registered for prior to the webinar. The first breakout room is designed to inform a current healthcare practice initiative, a current one. The second breakout room will inform a current healthcare policy consultation. So initiative will be the first breakout room, consultation will be the second, and the third one that you may have registered for, the breakout room, will inform how data is collected in healthcare settings. So, without further ado, I might move us now to the first major part of today's webinar, and that is a discussion panel. Today we have the privilege of hearing from several researchers who are involved in projects that focus on improving engagement with carers in healthcare settings. So we're going to hear from them about their work, what they can tell us about good practice in this space, and some of the opportunities and challenges that they see in translating that work into real-world practice. So I'm going to start by asking them some questions about the work that they do, and there'll be an opportunity to raise your questions with them a little bit later on. So feel free to put your questions into the chat. We'll collate them, and as we go along, we'll try to get to as many of those questions as we possibly can. Firstly, our first panelist is Dr. Rebecca Leidser-Powell, is behavioural scientist at the Cancer Institute of New South Wales. Cancer Institute New South Wales Early Career Fellow within the School of Psychology at the University of Sydney. And she was our final presenter at the last webinar on empowerment and resilience. Thank you. Sarah Ivinian is a research fellow at the UTS, or the University of Technology Sydney Ageing Research Collaborative, and Impact at the University of Technology Sydney, UTS. Thank you. Daniel Doe is a social policy analyst and senior lecturer in social work at the University of Western Australia. And Layla Hallam has a number of roles as a consumer advocate and representative, and is employed as a consumer advisor to the Sydney Local Health District. She's also an honorary associate with the Menzies Centre for Health Policy and Economics in School of Public Health at the University of Sydney. Thank you all. So can I start with a general question to the panel, and I'd invite you just to jump in as you feel appropriate. Maybe you can just start telling me a little bit about the kind of research that you've been involved with in relation to carers and healthcare. Maybe we'll start by Rebecca, if you want to jump in first.
Sure, thanks, Hugh. So I am primarily a psycho-oncology researcher, and that means that I do research mainly within the oncology or the cancer setting. So looking at the psychological and social elements of living with cancer or being a carer to someone who's living with cancer. And my research has mainly been in carers of an adult with cancer. So I guess that's distinct from in the pediatric oncology setting, where a carer might have some very different roles and rights and responsibilities. So the work that I've done has mainly been in that adult setting. And the types of work and research that I've done with carers is mainly around the role that carers that have in the medical consultation. So how they can be involved in the medical setting, in medical decisions, and how we can educate and upskill health professionals to better engage with and support and encourage and recognise carers.
Thanks, Rebecca. Look, we'll both go through to Sarah, then Daniel, and then Layla.
Great, thanks, Hugh. Hi, everyone. So the kind of work that I've done with carers, and I guess the two sort of main projects that I'll be speaking about today, was one specific one related to COVID and bereavement during the pandemic, where we looked at the mental health and support needs of Australians who'd experienced the death of a friend or family member who died during that time. And we really looked at their experiences before the death, so at the end of life, at the time of death, and after the death as well. So looked at their mental health and support needs. And then I've worked on a few projects with carers, but another one that I kind of wanted to speak about today was called the Caring at Home study, which some of you might be familiar with. And this was a study, it was an initiative to help support carers provide symptom management to people getting palliative care at home. So it was helping to upskill nurses to train carers to confidently manage symptoms using subcutaneous medicine. So I'm very keen to share some of the evidence we generated there.
Okay. Thanks, Huge. My research with carers largely focused on understanding carer well-being and their lived experiences. I've been involved in projects that sought to understand how the carer strain index, for example, can adequately measure the conditions of carers and what that meant for carer well-being improvement interventions. Currently, I'm involved in a project among the multicultural communities trying to understand the care transition experience of multicultural carers and the strategies that they are adopting to be able to go through the care planning system adequately. There are other ongoing projects with carers trying to determine how we can harness their knowledge in developing care transition toolkit for multicultural families.
Thank you, Daniel. I'm Layla. I feel like I'm the research novice of the group, but I'm primarily a consumer who dabbles in research. And the reason I do that is because I'm continually involved in research design and trying to move our research design into evidence-based. And where I don't see the evidence coming from a patient perspective, I try to work out how I might be able to plug those holes. And that arose, I think, similar to Sarah, I have two main areas of research. One of them is in consumer involvement and how they contribute to service designs. And also specifically for this was the I was drawn into some research during COVID with regards to what happened to families and carers when they in our hospital systems. And of course, that wasn't just in Australian or in New South Wales, but not just Australian. It was happening all over the world. And it was about what happened to the families and carers during COVID, and really what did that mean to the role of families and carers as patients in care. So my research was just about trying to really consolidate the importance, or actually began to understand the importance of families and carers to patients and their care. So to help us then build the case of why we shouldn't be locking out, we shouldn't be locking out our carers again.
Yeah. Well, that's really interesting. Can I just pick up on that one? I think we can all sort of agree that evidence informing practice is a good thing. And I could imagine what that looks like as a sort of a general concept. What does that actually sort of look like in terms of what you do sort of day to day?
The reason that I think it's really important is because when I sit on so many committees and working groups and steering groups and all of those things, and what usually happens is when, as a consumer representative, when you're in those environments, there tends to be like one or two, or maybe if you're really lucky, 3 of you in a group of 20. And I suppose what that means is that there's an imbalance of the voices. And so if you are articulating a particular position, it can often be seen as an opinion. And sometimes it is. Sometimes it is an opinion. And what we're trying to do is actually put knowledge behind that. So whether it's from the knowledge base that already exists in our evidence, or whether it's actually from speaking to patients in real time to genuinely understand what's going on. For me, it's really important that it's not just my voice that's saying something. It's actually able to be backed up. And there are a few ways of doing that, but evidence is one way.
Yeah, interesting. I just want to take it back to the panel now. Obviously, we're talking about carer engagement today. From a carer perspective, what are do you think the main ways that carers engage with healthcare services, and why is engagement important? Invite you, whoever feels comfortable, just to jump in first on that one.
Can I have a go, considering that's what my research was specifically about? One of the questions we were trying to answer is how important is it that families are actually there? Families and carers are actually there during a health service episode, if you like. So I'm speaking specifically, so whilst it extends right across the health continuum, specifically what I was looking at was what happens when we lock families out, disconnect families and patients. When
the COVID experience. Yep.
The COVID experience, that's right. But in doing that, we had to understand, well, what is the role that families and carers? So when I say families, I definitely mean carers, but I sort of speak maybe, that whole unit of people who surround a patient and their care. But what we find, excuse me, I'm choking. But what we found was that actually everything that we have known as instinctively the importance of families being there is actually demonstrated in evidence. There are better patient outcomes. There are better, the patient has better quality of life. And that's for a whole host of reasons that actually most people already know. So there are things like, families provide the scaffolding around patients that improve their ability to actually do things that are good for them, to help them, eat the right food, do the right exercise, take their medication on time, take the right medication. So all of those things that we just think, that's just really periphery stuff. It's actually really important from the position of me getting the best out of my health care needs. So families are integral to that. And that was absolutely demonstrated in evidence. So
I think adding to what Layla's just said about really them being so essential to achieve best practice care is that they're in this quite unique position where they understand the needs and preferences of the person better than most. So I think they're really key people to provide person-centered care, because, you know, they know their illness history, they know their interests, they know their preferences, and they really have a unique knowledge of the person. So I think that's another key thing to consider and why it's so important to engage them.
Yeah.
And I might add, so I think one of the other ways, and Sarah touched on that, is around values and preferences and needs of the person with an illness. I think one of the key ways that carers can be involved is in decision making. So, you know, we see this a lot in cancer and in other chronic illnesses, where there's often not one straightforward option that you know, to choose. Sometimes, you know, there might be different medications that are available, or there might be a choice between, you know, surgery or radiotherapy. And what might be the right decision for me is not necessarily the right decision for you. And that's about, you know, lots of factors like our lifestyle, preferences, values. And I think the research has been, you know, emerging and building on itself over the last 20 years in how a patient and a healthcare professional can make good decisions together. But really the evidence has been lacking around how a carer is involved in that. And the reality is they're very involved. And I think that this is a really crucial part of the way that carers can have a real impact in the medical setting is the way that they are involved in decisions. And it's, you know, and it plays out in many ways, like helping with research of different treatment options, or helping to understand the information that's being presented, being a sounding board to the person with an illness, or helping to communicate, as Sarah said, like helping to communicate, you know, the person with the illness's needs and values.
Mhm.
And I guess one other thing is they also help to enact the decisions. If you're going to, you know, choose radiotherapy and you need someone to drive you every day for 7 weeks, carers need to be on board with that.
Sarah and Layla, I know that you've done a lot of research in the sort of COVID-19 space, and it feels to me from a little bit of a distance from that there's sort of almost a contest of ideas here. If you go and talk to healthcare people, they'll say, you know, you need to keep separation with COVID for infection control and those sorts of things. And then you speak to carers and you can see the positive side of having engagement in the healthcare sector. And we can have that sort of fight between those two groups, but what does COVID-19 sort of maybe taught us about maybe more productive ways that we could sort of navigate these crises, you know, if it happens again?
Shall I begin?
Yes. There's lots to say about this.
Yeah, there is, because of course, one of the things that did actually happen was, yes, families were locked out. So in New South Wales, the first response was to lock out the families. And what that meant was that staff then had to step up and do a whole lot of things that in the past, when families and carers were actually there, they didn't need to do. Things like, you know, holding someone's hand because they were really scared. So comforting and calming. We had things like feeding. We had things like, so the mechanics of it, there was that element of it. That then staff now suddenly had to pick up. So I mean, on top of everything else they had to do, they had to now pick that up as well. Then in addition, what was happening was that the information sharing almost disappeared. So even stepping back from what Rebecca was saying from a point of shared decision making, sharing information is what families do too, both receiving and giving. So they're sort of builders, they're bridge builders between patients when they're ill and they're vulnerable and they're really too sick, or they're scared and they're frightened, and all of those other things. The families then are able to give the history. They're able to share what's worked in the past and what hasn't. They're able to then give a really good profile. That during COVID, that disappeared. So then suddenly what was happening is that things were being done that probably could have been done better if they had more information around it. So I suppose, so that led us to actually step in and say, okay, how do we do this better? And of course, it was all about infection control, wasn't it? I mean, that was the thing. We can't have families coming in because they're going to bring COVID in with them. But what we did is we did some research around that. And what we found was if they use the same infection control procedures that they were using with staff, we could identify who were the core people that these patients needed to be with them, and then we could apply the infection control procedures to them. And what we found is anyone who had someone in hospitals willing to do anything to be able to get into a hospital, and if that meant they had to stay home and not go out anywhere or mix with anybody just so that they could step into the hospital, they were prepared to do it. So, and the infection control process actually changed as a result of us being able to say, hey, look, as important as staff, the way that we manage the staff situation, we can do that with the core people who we know are the most important people to those patients. So it was just maybe saying, okay, we talk about partners in care, but we don't necessarily, that doesn't kick in when we need it to. So we were trying to highlight that they are actually the partners in care, just like the staff.
And that's something that we certainly found in the bereavement study, was people, or the people that we interviewed, really felt concerned when the person that was in hospital or in residential aged care was without an advocate, and decisions were being made without them. The other thing I wanted to say that was really interesting is because of the restrictions that we had during COVID, it was often only one nominated person that was able to visit. And people described the increased pressure that put on them as being the sole communicator with the rest of the family, and the only person that was receiving information and then had to relay the information. So I think if we're thinking in hindsight, there probably needs to be something put in place to consider that, not to put the pressure just on the sole person, and also recognizing that there's often more than one carer. There's multiple people, and as Layla was saying, the family unit often takes on different roles. So it's something to consider also.
Yeah.
Yeah, sorry, I was going to jump in a little bit.
Okay.
To just also add some of the areas we found carers well engaged in the healthcare setting is the care transition planning stage. When people have to be discharged from the hospital, for example, there's a conversation, what happens after hospital, all the things that you need to take into account when you take the patient back home. So they are deeply involved in that. We've also seen that carers are largely involved in quality improvement purposes through feedback. I mean, the evidence is clear on that. When you are in a hospital setting, occasionally there are surveys, feedback surveys that they provide to hospitals just to improve the care system. So those are some of the areas that we found carers engaging in the healthcare system.
Yeah, certainly COVID has highlighted a number of really important issues, and that's come up in the chat as well, where there's some nice points which are made around consent and information transfer, admissions, and also just the centrality of families in the communication process and the problems where that breaks down. Daniel, just to come back to you for a moment, just want to dwell a little bit about carers and their own health needs. What do you think carers need from the health system, and are they actually getting what they need?
Yeah, thank you, Huge. Now, the healthcare system or care system generally, whether in health or anything else, they've been traditionally designed to focus almost exclusively on the care recipient, without any reasonable provision for the person providing care for this person. And to this extent, some of the ongoing health issues that carers themselves face, they go unnoticed or they are not attended to. In our recent study, we found quite a number of carers who have very severe ongoing health conditions, whilst they are also providing care. But the concerning thing for us as researchers in that study was that even the carers themselves prioritize the care they provide over their own health needs. And that's quite serious. They've reported, of course, frustrations with the healthcare systems and services. Perhaps what they are not getting is a complete understanding of their well-being within the care space. More also because of the design things. So we think that it would be great if there is some provisions in place in any healthcare setting for carers to occasionally or periodically conduct a carer well-being fit or carer fit check to see how carers are going, how they are doing in the healthcare space. Often they are ignored in this space, and that has implications for the quality of care they also provide.
Yeah, thanks, Daniel. There's a great little comment just came into the chat about thinking about some sort of the structural forms of support too that we can sort of think about around care. It's not just listening, but also some of the more tangible aspects.
Hugh, can I just cut in there? Just so more of a logistical thing. I think if carers are more incorporated into how care is delivered, that does take off a burden for carers as well, because then we're getting the right care delivered in the right way that the carer can actually then support and maintain. And that in itself is helpful as against, being more disconnected from what happens and then having to take that load. So being part of the decision-making is also good for the carer's well-being as well, because they're being able to make it work for what works for them as well.
Yep.
So just the mechanics of how we deliver care can actually support carers too.
Thanks, Lila. Rebecca, just to come back to that comment in the chat before about communication in healthcare settings breaking down. I know that you've done a little bit of work about communication strategies for healthcare professionals. What are some of the sort of practical things that we might be able to advise those professionals to try to implement?
Yeah, I think, thanks, Hugh. I think it's a really important thing, is upskilling and providing education to healthcare professionals about communication, and that's increasingly been done in undergraduate, postgraduate studies, and then in professional development. But oftentimes communication with the families and carers hasn't really been included. So this is something that we've done quite a lot of work on, is developing some guidelines, some communication strategies for health professionals to be able to engage with and communicate with carers, and also to be able to manage some of those trickier situations. I saw a comment before about kind of consent for information sharing. So we have guidelines around that, and how health professionals can communicate with the person with an illness and their carer to navigate those complicated situations. And I think another element of that is practical skills, like things like rapport building with the carer. And I think these are so crucial and relatively easy to enact and quick to enact, but can have huge impacts. So, for a health professional, learning the carer's name and, asking them about themselves, acknowledging their presence, and demonstrating respect and recognition to them in a couple of sentences even is better than nothing, and I think can have a really huge impact. So we've done, we've created these guidelines, and I'm happy to share them with people. They've been published and have been, rigorously developed and evaluated, and we've actually turned it into online training and been able to really demonstrate through that online training. We've done an evaluation of that, and that this training can have a really big and significant impact on people's confidence to be able to communicate with carers, which I think is just so crucial.
Yeah, thanks, Rebecca. Daniel, some of the sort of practical steps that sort of Rebecca was talking about, I think you could imagine that have wide applicability. But are there sort of multicultural considerations? We do need to be flexible about how we sort of implement some of these interventions.
Yep, I perfectly agree. And the issue of communication is quite key. But perhaps let me just share with you a brief story from one of the studies we just conducted. I was conducting an interview with one carer, and we were using an over-the-phone interpreter. And in the middle of the conversation, the carer just stopped me and said she doesn't want to continue with the conversation. I said, "What's the issue?" She said, "What the interpreter is interpreting is not what I'm saying." So, she felt the interpreter was a little bit abusive as well. Now, often when we talk about providing services to multicultural communities. We talk about cultural competency training, we talk about everything, but there's this huge gap of communication, huge gap of understanding each other, and most healthcare settings make use of interpreters, but how sure are we that the conversation is exactly what we are expecting? Now, so then there is a need for us to rethink how we approach engaging with carers from multicultural communities. I see the issue from two sides, but the supply side and the demand side. Supply side is what we are doing, which is the cultural competency training for people, but also the demand side of things, the carers themselves. There's very little understanding, there's very little information on services, healthcare services, and how they should engage with that. So a bit of advocacy among these communities to really speak to them in the way that resonate with their cultural profile and understanding, to be able to engage effectively. Because when we build the supply side, but we don't build the demand side, then we are just not doing it.
Yeah, that's really important stuff. Thank you, Daniel, for sharing that. Got time for maybe one more question I'm going to pose to Sarah before we wrap up the panel. But if you haven't had the opportunity to pop some responses into the poll that we put up earlier, please just take this opportunity to do so before we move into the next section of today. The last thing, Sarah, I wanted to get to was, look, we've talked a lot. I think we're thinking about hospital healthcare settings and formal things, but what about the next step, and when obviously people return home? What should we learn about some of the work that you've been doing in that space about supporting and upskilling carers about that post-healthcare engagement?
Yeah, so I worked on the Caring at Home project as part of it was a national project, and I was part of the evaluation, which was aiming to upskill nurses to actually train carers to take on an expanded caring role for people receiving palliative care at home. So to really take the pressure off community palliative care. And also we found that carers were actually really motivated to do this and take on the caring role, but they're a bit worried and they're a bit hesitant about making mistakes, and they didn't have the confidence to do that. But what the Caring at Home program did was to develop sort of a multi-pronged program of support that included an education, like a training session with the registered nurse, also resources that were developed for them to refer back to. And then also there was a 24-hour phone support line that carers could use if they ever needed help, additional help to administer subcutaneous medicines. And we found that it was really effective in increasing their confidence, skills, and knowledge to actually provide that symptom relief at home, which was really something that people wanted to do anyway. And we found the success of the program was really about having those 3 layers of support. And I think the phone line in particular was just that extra sort of safety net. Like, they had the resources, they had been trained, but just in case, they had someone they could call to take them through the steps. So yeah, it can be done, I think, with the right support. And if carers are willing to, they're actually able to take on that role, which was amazing.
Great. Thanks, Sarah. So I just wanted to just pause here and just encourage, again, the comments coming through have been great. And if you have some thoughts about anything you'd like to sort of ask the panelists and sort of pose to them, please pop that into the chat and we'll make sure that we get to those. But just while we wait for a few more comments to come in, Daniel and Rebecca, I might just throw back to you. Your work has looked at that measurement issue about how carers are going and the impacts on the caring role. Can you tell us a little bit about what is needed in healthcare settings to identify and respond to the strain of and distress that carers might be reporting?
Daniel, do you want to go?
Let's go first, I'll follow.
Okay. Thanks, Hugh. I think this is a really crucial one. So something I'm really passionate about actually is developing, systems and processes so that we can kind of formally integrate distress screening into clinical settings with carers, because I think that that's just something that, we know that many carers have high rates of anxiety and depression. We see that in the evidence base. In the cancer setting, it's as high as the person with cancer. Yet we don't have really formal screening and pathways for carers, and I think that's really desperately needed. Something I'm trying to do in my current fellowship is developing and testing a process of screening for distress, and then not just screening for distress, but then what do we do next? Because I think that's one of the crucial things is once you, as a healthcare professional in a variety of healthcare settings, once you find, that someone is experiencing anxiety or depression or stress, we need pathways to be able to support that person and to be able to direct them to appropriate support. So I think that's something that's really crucial is, not only having screening, but having pathways mapped out for carers and where they can go for appropriate support.
Yeah, and just to add to that, quite similar to some of the things that we are doing right now, we think that the whole conversation of carer well-being should be integrated into healthcare system. There has to be a deliberate decisions to include carer concerns into the healthcare system. Perhaps, as I said earlier on, they could develop systems to screen, as Rebecca has said. We are trying to pilot something with really developed a bit of indices, an index to check, one, what is the severity of the health condition of the person being cared for versus the carer strain index score of the carer. And then we put this in a matrix to give us the actual condition of the carer. That gives us at least a number of pathways, because carers are different, their experiences are different, so that we can be able to provide targeted services or interventions to each carer based on what they need in a healthcare setting.
I'll ask a really maybe contentious one, which is just surrounding the legislative context and legislation around consent. Is there anything from your practice engagement or the research that might suggest where some of the existing legislative approaches around providing an access to information for carers and management of information sharing could be improved?
Is that to everyone?
Yes, it is.
Layla, you unmuted.
I was just going to say, so I haven't got research, but I was going to say one of the biggest areas that we could do better, and it could be a learning thing rather than an actual legislative thing, but that's about the thing of privacy. Often privacy is used to exclude carers from what's going on, whether it's doing a checkup or whether it's giving back important information or whatever. So, so privacy as an intent to make sure we are supporting the patient and their needs to take a step back and say, back to the patient to say, what would you like? Do you want your family here with you? Rather than at the moment we assume that privacy overrides everything, and therefore often we shoo away people when we really shouldn't be. So,
and I think that the evidence backs up that comment, Layla, in that sometimes there are difficulties, with, and it can be used as an excuse perhaps to exclude carers. And I think it's this real balancing act. And I've spoken to a lot of health professionals who have trouble knowing, how do I support the information needs of a carer, but how do I enact what the legislation tells me around privacy and confidentiality for the person with illness? And I think it's very tricky, and I think it needs to be very nuanced. Because I think
to find out that information, and I'm just thinking about things. There was another comment that was asking, open visiting hours. Am I guided by these, or can I sort of move in and just stay for as long as it's necessary to care for the person?
I love visiting hours. My life has been around visiting hours over the last 4 or 5 years. So I suppose we tend to lump all visitors into the one bucket. So, whether we're bringing flowers or whether we're the person who is actually, supporting the information needs of the patient or, the emotional needs and all of those things. And they are distinct. There's a distinctness between who I need to be with me versus who I'd like to be with me, but really they're not part of my circle of care. So visiting hours is a bit of a catch-all. It gets us into trouble. So one of the things that we have been trying to do is pull it apart. And so let's talk about partners in care and what kind of access they should have. And of course, I believe it should be 24 hours, which includes comfortable seating, it includes meals, it includes a bed if need be. We do it in pediatrics. If we sort of extended our thinking and said, okay, for those who choose, so that's not, you don't have to do any of this, but if you want to, and if it's critical enough and it's an end of life or it's a whatever, it's a point where the patient needs you and you want to be there, we should be welcoming environments because we know that that helps the recovery of the patient too. So,
yeah, it's all different forms of engagement, but to sort of, whether it's convenient for who, it's things to manage. Another version of that is to, there was a question there talking about timing of when should information be communicated. And sometimes it may be that, when information is communicated, when it's convenient and when the whole schedule opens up for the healthcare professional. And so it may be a conversation around timing. And when those conversations are had, might also be a nice thing to be part of the chat conversation as well. So any thoughts about timing, perhaps, or guidance might be provided about to healthcare professionals about when very sensitive information is communicated to carers?
Can I just say, one of the disconnects that we have is we have visiting hours, and in some places they're stringent, in other places they really don't care, and that we sort of need to work that out. But what we have is a disconnection between the visiting hours and the clinical rounds. And you have a lot of families and carers who want to be there. If they're going to be partners in care, they actually need to be there during the clinical rounding. So we can have family members who will be sitting with their patient for 12 hours, go get a coffee, the clinician comes in and they're gone. So we've got to get better at that. We've got to get better at saying, okay, clinical rounds happen in this ward or, at this time. So if you want to be here, if you can be here, great. And if you can't be here, then let's work out what you do need. So it's about just getting into the spirit of, if you're a partner in care, that means a whole lot more than just a name.
Yeah, absolutely. Lots of really good issues, I think, raised by the panelists today. I'd just like to thank you all for your contribution and sharing your expertise and experience in working in the healthcare system. So thank you. We're going to have a quick 5-minute break, and then once we come back, we refreshed to jump into the breakout rooms. You'll be automatically allocated to a breakout room that you selected when you registered for the webinar, so there's no need to remember which one that was. Unfortunately, just with the design of Zoom and everything else, we can't accommodate some changes to breakout rooms or moves between them. But we're going to record all the breakout room discussions, and all registered participants for today's webinar will be provided with an opportunity to contribute their knowledge on all topics through an interactive form after the webinar. So with that, please take the opportunity to grab a coffee or whatever it might be, and we'll see you in 5 minutes' time. Thank you.
Hi, I'm Prudence Granger, and I was the carer for my dad who had early onset Alzheimer's. This is Care to Share. On this show, I have open and honest conversations with carers. We talk about the challenges, roadblocks, and joys of caring.
I think the only reason I've been able to do so well as a carer late in life is because I was a carer when I was younger. And I think those little things that happened had primed me.
A carer is someone who cares for a family member, loved one, or friend living with a disability or illness.
You do it because you want to do it. It's not a chore, is it?
No, not at all. I mean, still, I'll miss being with Bev today.
Carers are often hidden and misunderstood. I'm excited to share their stories with you.
It just felt so natural that it didn't really feel like I was a carer. It didn't really occur to me that that was what I was doing.
When am I the carer? When am I the partner? For us, that shifts the dynamic of our relationship because you're not on equal playing ground anymore.
I would like to dedicate this show to my dad, Timothy Granger. He passed away during the recording of this season. Caring for him was an experience that has changed my life forever. He was my biggest champion, my best friend, and now my greatest inspiration. Caring can be a lonely experience. I'm of course grateful for the time I shared with my father as his carer. We had plenty of fun and shared a lot of love. But for me, the struggles did eventually outweigh the joy, and the lack of community or support in the caring world can be very isolating. This podcast is an opportunity to break down the stigmas around care by hearing firsthand the stories of those who live this experience every day. Please listen with care.
Welcome back, everybody. I hope you had a useful, engaging and productive time in the three breakout rooms around practice, policy and data. And just to reiterate, it is all recorded. So if you are interested in capturing the specifics of what happened in the other breakout rooms, certainly that will be accessible. But what we do have an opportunity now to do is to give the high-level overview about some of the major themes that have come out of the three breakout groups. So what I'm going to do is firstly start with the practice focus consultation theme, which was around the Murrumbidgee Local Health District Carer Coordinator Program. And we had Melissa Docker facilitating that, and Belinda Simpson as the scribe. Not sure which of you would like to sort of feedback the overall themes that came from that breakout group.
Thanks, Hugh. Yeah, so I facilitated that session. We got a bit of an overview of what that new program was going to look like from Monty and Molly at Murrumbidgee Local Health District, which was great. And then we opened up the floor to some questions about how that kind of might work in practice. We had a bit of a discussion about pathways for identifying and referring carers, and some of the conversation about some of those challenges with both finding carers as hidden in the community, but also given that there's ongoing challenges with language and how carers identify, and ways in which the program could reach out to different places or organisations to find carers, or where they might be able to draw on some of those resources in the community. We also had a bit of a chat about prioritising and triaging carers who are referred to the service. So it's a carer network coordinator. We've had a bit of a chat, I guess, in the feasibility, just in regards to feasibility, about once it's up and running, you know, and if it is well advertised and there are lots of referrals coming in, you know, there's always that challenge then, how do you manage that from a resource perspective of facilitating support for those carers? You know, part of the conversation was about how would you triage those carers or prioritize them. So we discussed a bit of about assessment options for different that different programs and projects have used in the past, or different approaches, such as looking at preparedness, or looking at level of distress, and other ways that they might be able to facilitate that in practice. So it was a great discussion, and lots of good insight from all of the attendees.
Thanks, Melissa. That was really clear. We're going to move on to our second breakout group around policy, and Sarah Judd-Lamb, I believe, was facilitating that one. If you'd like to take the floor and give us a little bit of summary of some of the major themes that came out of that discussion.
Yes, thank you, Hugh. So in our group, we were looking at policy, and particularly we were doing some consultation to add to Carers New South Wales's response to the New South Wales Health Key Directions consultation draft, which is a policy guideline that links to the New South Wales Carers Recognition Act. And we focused on the key direction that most related to today's webinar topic, which is that New South Wales Health will recognise, respect and empower carers as partners in patients' care. We had some really great discussion with carer perspectives, professional perspectives, research perspectives around what that looks like. Some key things that came out of it. One is that we really need to look at what do these things look like practically in different parts of the health system. So emergency experience might be very different from the ward. And what does it look like for, say, mental health versus dementia, and just acknowledging the range of experiences, including rural and regional experiences. So I guess just some nutting down some detail around those different settings. Something we discussed a lot was around the critical nature of having staff in all of those settings know who a carer is, know when to kind of engage with them as a carer, and ideally just demonstrate empathy, even in small ways. And we talked about how, empathy is two-way, and that, we're dealing with a lot of the time staff that are under immense pressure and they might be experiencing burnout. And so where our conversation took us was maybe we need to look above just carer-specific policy at supporting general sort of health staff wellbeing and workload as part of the picture of improving that empathetic response. We also talked about the concept of empowerment and how where power sits in health settings. Sometimes it sits with clinicians. There's obviously importance to patients having power as well in terms of decision making and their own care, but also that carers need to be empowered and often feel that they're sort of locked out of that system. And so we talked about power and knowledge being something that can be shared in a team-based approach to healthcare, and something that maybe can kind of be not black and white who's holding the power, but that everybody's sort of able to work together in that partnership approach. I guess just kind of finally, one of our points was, and this will all be going into Carers New South Wales submission at the end of the week, is maybe we could aim a bit higher in terms of goals and have some aspirational principles, but also we need to think about giving carers a voice for when things are hard and frustrating. And I know that came out of our last webinar as well. So making staff a bit more comfortable about carers that are expressing when things don't go well, even up to whether there's rights of repeal and redress where some of these principles aren't implemented. So lots and lots of things to think about. We'll be incorporating all those into our response. So thank you to our breakout room.
Wonderful. Thanks, Sarah. And now just to turn to our third breakout group, which was thinking about digital patient records, actually, I'm not sure whether the conversation turned to the measurement of carer wellbeing. Lucas Hofstadter, I think, was facilitating that particular session.
Hi, yeah, we were talking about the use of wellbeing tools and the use of standardized measures around carer health, mental health, well-being, and sort of our conversation very soon went towards the issue that a lot of carers are tired of these measures, which was kind of our premise and our observance that started this breakout room, but also around the usefulness of these measures for themselves. And we found that part of the discussion was that really, if you want to, from a service perspective, we heard that what is much more useful is direct engagement and direct sort of trying to fully embrace sort of the person that cares, that provides the care, and to talk with them directly, because very often they either don't identify as a carer, or they're, and this is one thing that was found generally, that the needs of the carer, the well-being of the carer is entangled with so many different contexts that very often a singular and single-dimensional tool doesn't really capture what is going on in their life. And one way out of this is personal engagement. Another way is a more, and this is sort of the call to action for us, a more multidimensional, multi-contextual approach to measuring carer health and well-being that brings in not just the individual experience of the carer, but also how this interrelates with the caring experience of the person they care for with other institutional contexts. And we identified a range of problems around the measures that exist, such as that we work in silos, that both research and service provision, and within research and service provision, again, there's various silos that don't communicate with each other, and that we could greatly benefit from sort of transcending these silos that might be condition specific, that might be service context specific, And the other thing that we identified that is sort of an issue is that for many carers, there is no consequence, there is no effect for them for volunteering their data and for volunteering their engagement in such surveys. And it's one thing in research where sort of feedback loops are by design a bit longer, but it's a very different thing in service context where feedback surveys don't have an effect. And yeah, we came up with the conclusion that sort of we really need to rethink the tools that are used in that space. We need to make them multi-contextual, multi-dimensional, and multimodal as well. So in different forms of communicating this information, because one point that was made very early on was the best tool might just be a quick information about the emotional state that they're in at the moment and taking on a conversation from there. Yes, it was a very engaged, very fruitful discussion, and thank the participants of the breakout room. That was a great and very informative for us.
Thank you so much, Lucas. I think one of the things about a session such as we've had today is that we cover so much ground, but there's a lot of interconnected themes. Everyone will take their own sort of key points away from today. Certainly for me, issues around identification and recognize or labeling oneself as a carer or not, the issues that the difficulties that creates for healthcare systems and service providers is one sort of takeaway, just to reinforce that. Certainly, as Sarah mentioned, that sort of focus on, yes, the carer is important, but also seeing the carer in context and recognizing that as you shift context from out of hospital, in hospital, there's different considerations that come into play there. Certainly love the conversation we've heard today about empowerment, patient rights, collaborative relationships, information sharing. All those, I think, are really good links into conversations that have been part of the CKE in the past, in the webinars, but also things that I'm sure will come in the future. And also, finally, with Lucas, that again, kind of that question of engagement has sort of multiple meanings. From a research perspective, what does it mean to engage with potential participants in research? What does it mean to actually engage with the thing that you're trying to measure? So you're doing it at a proper deep level rather than just a surface level. And also thinking about true engagement in healthcare settings with all the different stakeholders there. So lots and lots of things for me to take away, and I'm sure for you today as well. If you are looking to take that next step, certainly I would strongly recommend engaging further with the Carers Knowledge Exchange digital platform. I know that there's a link which is coming up in the chat now. It's got a great and rapidly evolving research library where you can learn a little bit more about the evidence base around engagement and lots of other issues. There's also been, I'm sure, I've seen a lot of links come into the chat about specific types of research, but the CKE is a broad family of other research offerings that may be of interest. As I alluded to, viewing past CKE event recordings, the Knowledge Exchange webinars, research incubator sessions, spotlight series recordings, all these are fantastic resources. So have a look at the Get Involved page of the digital platform. And again, there's a link there in the chat to speak to that. We'd love to hear your feedback from today. And so we can build on today's webinar and continue to improve the events that we deliver through the Carers Knowledge Exchange. On your screen, hopefully you'll see a survey link shortly, and that can pop up where you can provide us with some comments, and that'll be really appreciated if you just spend a little bit of time to provide your thoughts about today and other things in this space. So thank you very much for joining us today. We hope you continue to engage with us in various forms through the Carers Knowledge Exchange. And as with all our other online events, we're going to end with just a short guided meditation led by the Carer Knowledge Exchange Care in Residence. Prudence Rose Granger as a reminder of the importance of looking after our own well-being. So over to you.
Thank you, Hugh. Hello, everyone. So this is just an opportunity to decompress after a very information-heavy session. So take a moment to arrive wherever it is you are currently. And most of us will be sitting down on a seat. So if you are sitting down on a seat, please make sure that both your feet are firmly planted on the ground. And then start to plug into the heels of your feet. As you do so, you might start to notice some sensation in the underneaths of your legs. And as you notice that sensation, follow it along to your seat and feel your tailbone becoming heavy to the earth. As the tailbone becomes heavy to the earth, you might start to feel a little bit of a natural lifting up and out of the body. Follow that lengthening as the crown of the head reaches towards the ceiling. And can you soften your front body into back, your back body into the chair or the space that is behind you? And then from here, doing a full body scan from crown of the head to tips of the toes. As you scan through the body, notice any points that feel a little more tight, or if they're holding any particular tension or resistance. And direct a couple of exhalations over those pockets of the body. And sometimes the physical body holds on to stress or tension or overwhelm that may be occurring in the mind. And so first, relieving the body is a wonderful way to then potentially relieve the mind of that stress. And you might cycle through the body just one time, or perhaps 2 times, or even 3 times, however many times you need to notice and decompress whatever is lingering or living in your body. And then move from your body to your breath. Watching the journey the breath is taking within you. And at first, watching out of a sense of curiosity. You're not here to judge the experience or shift the experience. Just acknowledge how it is that the breath is living within you. Is there a particular pace or depth to your breath? Is there any particular areas of the body that the breath is avoiding? If you notice any particular areas that the breath is avoiding, could you perhaps start playing with filling the breath into those spaces? At first, it might feel a little strange or uncomfortable. And generally, the breath avoids the places where you feel tension. But if you can start to invite the breath into those pockets of the body, that tension might begin to release with the breath. And starting to cultivate what is sometimes referred to as a 3-part breath. So as you inhale, feel your belly swell, then your waist, then your chest space. Pause for a moment in the fullness. And then as you exhale, feel the descent from chest to waist to belly. Inhale, filling up from belly to waist to chest. Pause in the fullness. Exhale, softening from chest to waist to belly. Taking a couple more breaths like that at your own pace. And then just as you did at the beginning, scan through your body once again from crown of the head to tips of the toes. Notice if anything has shifted. Are you feeling more at ease in your body? Is there more of a natural depth to your breath? Perhaps there's also a little more space between your thoughts. And then coming back to the process of your breath, concentrating on that 3-part breath, a little hold at the top. And allowing ease to follow the exhalation. And adding a little more structure to this breath with a count of 4. So I'll guide you to an even inhale and exhale to the count of 4. Allow your next exhalation to naturally conclude. And then inhale, 2, 3, 4. Exhale, 2, 3, 4. Inhale, 2, 3, 4. Exhale, 2, 3, 4. Inhale, 2, 3, 4. Exhale, 2, 3, 4. Inhale. Exhale. Inhale. Exhale. Inhale. Exhale. Continuing this breath, maintaining the count in your own mind's eye. And the attention to breath and the focus on the count is your anchor to keep you present. If you notice the mind becoming busy or distracted, gently draw it back to the anchor. Watch the breath, count the breath. Allow the anchor to gently leave your mind. Return to a natural breath and rest for a moment in the space you have created, perhaps feeling a little less cluttered, a little less overwhelmed. Perhaps having the capacity or the clarity of mind to truly digest all the information you've received today. And then bring your hands together to meet and start to gently rub the palms of your hands together to feel a sensation arising. Maybe then a warmth builds. And then cup your hands gently in front of your eyes. Feel the warmth of your hands radiate towards your face. Breathe in the warmth. Gently blink your eyes open. Start to slowly absorb the different patterns and textures of your hands. And once that comes into focus and you feel ready to welcome in the rest of the world, peel away your hands to absorb once again your surroundings, the device that's in front of you that is connecting us. Thank you. If you have any questions for me, please pop them in the chat. My name is Prue and I am the Carer in Residence for the Carer Knowledge Exchange. If you're interested in more of the work that we are doing there, the links to that page were shared recently. Thank you.